We're going to walk through how to do a rapid sequence intubation. The first thing you want to do once you have your patient is to make sure that they have 2 functioning IVs. That's what you're going to use to push the medications as well as any IV fluids you may need for support. Oxygen, right? You want to have that patient on oxygen. You want to have, obviously, the oxygen source for this intubation. And you want to have your patient on a monitor. In terms of monitoring, they need to be on a cardiac monitor. Whether you use your defibrillator pads or not is up to you, and pulse oximetry. You want to make sure that they're oxygenating their blood, and you're going to be using that to make decisions while you're intubating your patient. I like to make sure that I have my team ready. I'll typically be at the head of the bed with my RT, and I'll have my nurse with my medications at the IV site. They both assist me with intubation as well as monitoring the patient's vital signs. The next step that's really important is to give that patient a period of pre-oxygenation if you have time. And it doesn't really take more than 5 to 8 minutes. What I mean by pre-oxygenation is giving them that chance to really fill up their lungs and get their oxygen level as high as possible, so it can give you that buffer if you run into some trouble while they're paralyzed and sedated during your intubation. If they're awake and conscious, I'll have them on a high-flow nasal cannula as well as a non-rebreather mask, and I'll tell the patient, I'll say, please, I want you to take 8 to 10 deep, slow breaths, vital capacity breaths, really big in and out. If they're not conscious and they can't follow instructions, having them on the high-flow nasal cannula and the non-rebreather is still important, and they'll be oxygenating themselves as they breathe. So while your patient is pre-oxygenating, it's a great time to do your equipment check. I like to have all of my equipment laid out in front of me on the right-hand side with my RT, and you want to go through each piece of equipment to A, make sure it's there, and B, make sure that it's working properly. The first piece of equipment is going to be suction, right? This is a Yankauer tube. You want to make sure that it's working, that it's connected to a suction canister, and that it's somewhere you can find it without needing to look. Oftentimes, you'll run into vomitus or oral secretions or blood while you're looking at the vocal cords, and you want to be able to suction that out immediately. I'll take this and tuck it right here underneath the mattress or the pillow at the head of the bed. That way, if I'm looking at the vocal cords, I can blindly just go and grab it. The next piece of equipment is going to be your laryngoscope. The laryngoscope is what you're going to be using to visualize the vocal cords. This one has a Mac 4 curved blade, which is my preferred blade. There are straight Miller blades that we'll sometimes use for peds, or if it's a preference of yours, you can use a Miller blade. I'll have a backup smaller Mac 3 that I'll use for smaller adults or children. You want to make sure that the light is actually working, right? That your batteries haven't died while it's been sitting in the drawer. So make sure that light source is solid and turns on every time you engage that blade. Your next piece of equipment is going to be your endotracheal tube, your ET tube. This is a 6.5, but typically I'll have at least a 7.0 and a 7.5 for my standard size adult. Sometimes bump it up to an 8.0 or 8.5 for a really large male, or it can go down to about a 6.5 for a smaller individual. But those are my standard go-tos, 7.0, 7.5 on the tray. They'll be close by if you need to switch it out. In terms of your endotracheal tube, you'll also need a rigid stylet, right? So this is a rigid stylet. It has an obturator on the end, a rubber obturator. And what you're going to do is use the stylet into the ET tube to give it some form so that you can manipulate it into the airway. And when you're going to be changing the form of that stylet, I like to have it like a hockey stick, right? So it's really straight, 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 straight. And right before the balloon at the end, you do a 35 degree angle anterior. That's going to help this tube go into the airway, which lies a little anterior. If it's too straight, you have a risk of it going into the esophagus. And if it's too angled, you're just going to get hung up on the vocal cords. You do not want it to go beyond the eyelet of the ET tube, right? So the tip of your stylet should not be protruding outside. That's going to cause damage to the airway. I tuck it in right before the eyelet starts on the ET tube. So now it's all prepped up and styleted. The next step is to make sure that your balloon is actually functioning, right? So I'll take a 10 cc syringe, and I'll fill the ET tube balloon and make sure there's no air leaks. You can feel it. It's nice and tense. No air is escaping. At that point, you deflate it again so that you can pass it through the vocal cords easily. I'll set that to the side. My RT will know where it is, so it'll be ready. I want to make sure that I have a bag valve mask, right? It's the bag that you'll be attaching to the end of the ET tube to actually inflate the patient's lungs, and a mask, right? A mask is a good thing to have because if you run into trouble with the intubation and you need to oxygenate the patient in between attempts, well, you're going to bag valve mask them. And we show you how to do that in a previous video. I also like to have some other rescue devices, right? The first one I'm going to have is going to be a bougie. This one's twisted up for storage, but I'll teach you how to use this if you're having a hard time seeing vocal cords or getting the ET tube in. The other backups I'll have will be an oral airway for my bag valve mask or even an LMA, and we'll teach you how to use all of these in separate videos. You'll need an end-tidal CO2 device. This is a small plastic device that will change colors to confirm that you're in the airway. When there's CO2 exhaled from the lungs, it goes from yellow to purple. Alternatively, if you have an end-tidal CO2 monitor, you can connect that to the end of your endotracheal tube, but it just helps you confirm that you're actually in the airway and not in the esophagus. I'll make sure that I have a set of McGill forceps. These are really handy to have if you have something blocking the airway. They're ringed at the ends, so they're blunt, and they're shaped just like the airway. So when you're in there looking at the vocal cords, if there's something obscuring it, a foreign body, you can go in there, grab it, pull it out. It's also useful to help lift up the tongue sometimes if you're getting caught up on that. And then finally, I'll just make sure that A, my RT is ready, that my monitors are on, that my nurse is ready with my medications, and we'll proceed from there. The next step is to make sure you have your patient properly positioned. So I'd be at the head of the bed with my RT at the right, all my equipment at the right, my nurse at the IV line. We can all look at the monitor and monitor that patient. And then I'll have that patient's head right about the height of the lower end of my sternum. I don't want to be bending way over to see the vocal cords. It gets awkward and it makes it difficult. So bringing them up to the lower end of my sternum is just about right. You also want to make sure that you have that patient in the sniffing position that we discussed in a previous video. The sniffing position is a little bit of flexion at the head and elevation at the occiput. So you're really straightening out the angle of that airway, trying to make it as straight as possible for your look and for your intubation. In order to do that for your patient, you're going to, again, just flex their head as long as there's no C-spine precautions, just a little bit of flexion, and I'll often add a small pillow or a towel roll at the occiput to give that elevation. It really brings up the jaw and decreases that angle. Once they're positioned and everyone's ready, I'll have my nurse or my pharmacist push my medications, the sedative followed by the paralytic, and then you wait. You wait to make sure that your patient is sedated and paralyzed, realizing that this can take anywhere from 30 seconds to sometimes 1 to 2 minutes, so be patient. You want to make sure they're sedated because they won't be responsive, and the great way to figure out if they're paralyzed is looking for that laxity in their jaw. When you're moving their jaw and there's a lot of laxity, you feel that musculature kind of chill out, then you know you have good paralysis, and you're ready to move on to the next step, which is actually looking at the vocal cords. It's at this point that I'll remove the oxygen mask. I'll leave the nasal cannula just for some apneic oxygenation. You want to grab your laryngoscope, and when you hold it, I hold it in my non-dominant hand, my left hand, with the butt of the blade at my hypothenar eminence, 4 fingers grasping here, and my thumb on the handle for control. And when you're going to be using this, you're going to be doing a lifting motion, not a twisting motion, not a flexing at the wrist. It's really going to be an in and lift. I'll go to the patient's mouth. I'll oftentimes use my finger to pull that cheek so I can really get good visualization of the tongue. I'll place this blade into the right side of the mouth, sweeping the tongue towards the left as I bring that blade midline. And this part is where it's really critical. You don't want to be using the teeth as a fulcrum, right? You're not going to be flexing here. That's how you break people's teeth. It's really a in and a lift up. And I almost visualize it as I'm trying to bring that patient's chin to touch the sky. So I'm really lifting up here. A good 90-degree angle at the elbow and being close to the patient is going to help you make that move. And while you're doing that, you're looking, right? You're going to be looking for the epiglottis. Once you see the epiglottis, you want to tuck that blade forward into the vallecula, which will pop the epiglottis out, and then you can see the vocal cords staring at you, 2 white vocal cords. If you're having difficulty actually seeing the vocal cords, you can do external laryngeal manipulation where you're pushing down on the thyroid to bring the vocal cords into view. Once you found them, you can have your assistant hold it there. Alternatively, you can actually move their hand and they'll hold it where you need to be so you can see those vocal cords. You keep your eye on it. You'll ask your RT for assistance, hands you the ET tube, and you want to watch that ET tube go through those vocal cords. And once you're in there, you want to go 3 to 4 centimeters beyond the vocal cords. Remove your blade. Hold that ET tube against the teeth with your hand while you remove the rigid stylet. And at this point, your RT is going to inflate the balloon, or you're going to inflate the balloon. We'll put on our end-tidal CO2 detector once that balloon's up. And you now want to confirm that that ET tube is in the airway. Give a couple breaths. You're watching for color change on the end-tidal CO2, again from yellow to purple. And then have someone, either you or your RT or the nurse, listen to the bilateral lungs in the axilla and the epigastrum to confirm that they're hearing breath sounds over the lungs and not over the stomach. So once you've confirmed that the tube is in the airway, you can now focus on making sure it's positioned correctly. You want to get a post-intubation X-ray. You'll secure that tube, whether you use tape or a commercial product that actually secures the tube into the mouth around the neck. And you want to have your RT connect them to the ventilator, and your nurse and your pharmacist work on the post-intubation medications, sedation and pain control, so you do not have an awake patient with a tube in their throat that has the risk of actually pulling it out. And those are the steps for your rapid sequence intubation. The next step is really going to be making sure you have the tube in the right place with an X-ray, securing the tube with tape or a commercial device, making sure that your patient has post-intubation sedation and pain control, and vent managing. But really, the RSI, these are the steps that you need to do, and you'll be successful.